Hello, am I audible?
Yes,
Thank you very much. I will start with my brief introduction. I'm Nadeem Iqbal, and I have done FCPS Pediatrics, FCPS Neonatology, MRCP Ireland, and MRCPCH UK. And today we will discuss approach to the history station, and then we will discuss a case how to take a history of a child with UTI. My slides are visible. Okay. So perfect. In the history station, actually, there are five domains where you will get marked, and these domains are information gathering, clinical reasoning, management planning, communication style, and then your verbal listening and communication skills. So, in all these domains, you will be marked uh, below standard, meet standards, or borderline. And the point of these domain is like you have to take some good marks in all the domains so that if there is any deficiency in other stations, it can compensate. History station is also one of the station where you can get some good marks because you are already aware about the scenario when you are waiting outside the station room, and you have 3 minutes. You can make some notes and you can be aware of what case you are going to come across, as compared to the clinical stations where you have no clue. So you will find some scenario like this. Talk to Mrs. Ruth, mother of Jessica, 4-year-old girl who is referred by GP with the 3 episodes of UTI. Take the detailed history, and after the history, you have to answer the examiner questions. So when you are waiting outside, try to be very smart and use that time in a nice manner, and actually note down all these informations on a history sheet that you would be provided over there. Name and age of the child and name of the mother. You should be very clear what is the task, and write down the short background and plan and get ready and write down the points of the history. You can write down the headings of the history and leave 3 to 4 lines below every point where you can write down your important positive findings. Don't write the long sentences during the history because you won't have enough time. So only write the points, important points, only positive things. So you will start with brief introduction, like I'm Dr. Nadeem, one of the treating doctor here today. I believe I'm speaking to Mrs. Jessica, or what is the name of the mother here? So Mrs. Ruth, and I will ask few questions regarding the health of Jessica, and I will make short notes. Is that okay with you? So you have to take the consent properly, and after that you can ask the mom, how can I help you? What are your concerns today? So after that, let the mom speak whatever she knows. You can just write down the important positive findings only, and don't interrupt the mom when she's speaking. Try to be very show some empathy, and these things have marks actually. If mom says like anything about the family history, any positive, any other sibling who has the problem, try to I'm so sad to hear about that. Just some sentences to show the empathy. These things have marks. If you will not actually show the empathy, examiner will cut some marks. So be aware of these things. So once mom has finished telling you the presenting complaint or some details, then you can ask, is there anything else, mom, you want to share? If mom says no, then at the end you can say, thank you so much for telling the important informations. I will check with my team, and I will get back to you. So after that, the historian, the role player would move out of the room, and then examiner would have some time to ask the questions. So this is how it goes actually, this station of the history. And you have initial 3 minutes. In during these 3 minutes actually, you can make some initial notes, and after that you will start taking the history. So you should be very clear about the concerns, and then is there any previous health? In the beginning, you can, when the mom has told the initial concerns, you can ask like, is there any previous health conditions leading to these concerns? Any previous health conditions? So you can be aware about any chronic health condition that mom is having, that the child is having. So is it the new complaint, or there is any ongoing chronic condition like cystic fibrosis or anything that you will be aware by this point. So far, I'm not going to discuss UTI. I will discuss the UTI at the end. I'm just telling you the format that you should be aware of in any child with a chronic condition or any child with the new onset complaint. If the child is having chronic condition, you can ask when this problem started, where started, and how it was diagnosed, what investigations were done, and you can ask about the treatment. And in the treatment you can ask about the name of the medication, dose of the medication, frequency. Like if child is having some epilepsy and taking a lot of medication, you should know about the name and dose of frequency of all these medication, and when was the last adjustment done, and how is the compliance towards the treatment. And then you can ask about the total admissions, ED presentations, and if there are any ICU admissions. These things are especially important for children with the asthma or any other like epilepsy. These children can come to the ED frequently, and sometimes they need admissions as well. So after that, you can ask about the follow-up, like where the child is being follow up. Is it the OPD or some other, like any specialist OPD? Like if the child is having epilepsy, maybe child is following you and following some neurology team as well. So ask about the follow-up, and then ask about the services, if there is any multidisciplinary team involvement. And then you can ask about the past medical history, anything significant in the previous history, any allergies, and any other specific history related to the problem. Like if child is having cystic fibrosis, you can ask about the other relevant complications of the other system, GIT system, respiratory system. And similarly, if the child is having some other chronic problems like epilepsy, you can ask about the complication of the disease and complication of the medications. And birth history is very important. Immunization history, you can ask about this child. Shots are up to date, like child vaccination status is up to date. And then nutritional history is also very important. And then development history, you can ask some formal question, if are there any concerns regarding the development of the child. And if mom says like there are some concerns, then you can ask, refer to the relevant domains. And then family history is very important. You can ask like, could you please describe your family? And then ask, is there any other sibling having similar problem? Or ask about the consanguinity and miscarriages or unexplained death of the infants. And then social history is very important. Schooling is very important. You can ask about them, ask like a mom, are you happy with your finances? And how this health condition is affecting your family and other siblings. And do you have any emotional support? What services, what emotional support you are linked with, like so any social support or any psychologist? So these are important things you have to cover. You won't have enough time, but you should be very quick. You should memorize all these headings and quickly ask the questions. So if there is a new complaint, then you can ask like when this problem started, where this problem was started, and how it was started, and um, you can ask about the onset, course, and duration of the symptoms, and site severity and progression of the symptoms, aggravating and associating factors, and you can ask about the systemic review. Like if for the respiratory symptom, you can ask about if there is an ongoing cough or chest pain, and for cardiovascular, you can ask about any palpitations and shortness of breath. For CNS, you can ask about the headache, seizures, and for GIT, you can ask about the nausea, vomiting, and any constipation, weight loss, anorexia. Don't ask anorexia, but you should be aware. You have to ask. You can ask loss of appetite. So don't use any jargons. I'm just giving you a template, so try to avoid any jargons when you are taking the history. So and for the new complaint, you can ask if any investigations done so far, treatment given so far, services or any follow-up. And then again, past medical history, allergies, any complications, immunization, nutritional history, development history, family history, social history, schooling, and finances. So these all are important domains, regardless whether it's a new complaint or any ongoing chronic condition. So now we will focus on the UTI history. And for the UTI, the child, it can be a scenario of lower UTI, which we call cystitis, or upper UTI, which we call pyelonephritis. So you have to ask about the urinary symptoms, any frequency or urgency. A mom actually would explain you increase frequency or urgency. Then you can ask if mums doesn't share with you, you have to ask like if there is involvement of any systemic signs, temperature, or flank pain. If there is any temperature and flank pain along with the urinary urgency and frequency, this shows pyelonephritis or upper UTI. For the temperature, you have to ask for some more details, whether this temperature was documented and how it was checked, how often it's happening, what is the like, if was it happening every 8 hourly, 6 hourly, was it not settling, or was it settling with the paracetamol? So you have to ask about the pattern of the temperature as well. And then you can ask about the flank pain. If there is any pain in the flanks, it means it's a renal angle tenderness. So it's just pyelonephritis. Any established health condition, you can ask like if there is any previously established health condition that is causing this in these symptoms. So in like there can be some vesicoureteric reflex, or some renal anomalies, in which condition the children are more prone to have recurrent infections. So you have to ask about the recurrent UTI as well. You can ask like, is there any previous occurrence of similar complaints? So you have to actually check like how often it is happening. If there is a UTI 3 times or more than 3 times in a year, it means it's a recurrent UTI. And even if it's happening two or more than two, and one of episode it was pyelonephritis, it can also be recurrent UTI. So I will say it again, like if there are three or more than three episodes of UTI in one year, it is recurrent UTI. But even if it is two or more than two UTI in one year, but one of the episode was of pyelonephritis, it also shows recurrent UTI. So after that, you can ask about some how the problem started, how it's progressing, is it getting better or getting worse, how it's affecting child's activities of the daily life. Is there anything which makes it better or worse? So onset, course duration, site severity, progression, aggravating associating factors, and then some question systemic review. When it's a clear-cut focus, or it's a clear-cut case of UTI, don't ask too many questions about the systemic review. Try to actually save some time and try to be more focused towards the specific question. If there is a child with UTI, never forget to ask about the risk factors. So you have to ask about the fluid intake, any constipation, and retentive behavior and social factors. So you can ask the mom how much fluid he or she takes in one day. Mom won't be sure, but you can ask like estimated volume. And constipation, you can ask how many times in a day he or she opens the bowel, and is it hard to open? If it is hard to open, and are its mom mentions like the child is opening less than 2 to 3 times in a week, you can show them Bristol stool chart and ask about the what type of Bristol stool they are passing. And retentive behavior, sometimes they hold the urine, and it actually causes a problem. And holding urine can be due to change of school, change of home, and these can actually aggravate the UTI. Social factors, you can ask like, is family known to social services? Sometimes the children with child abuse, they present with the recurrent UTI, and there is no other obvious cause for that. Perfect. And then you have to ask about some red flags. Like if child is not growing well, child is having poor urinary stream, and there is some ballooning. And if there is any family history of UTI and there are some spine issues, you can ask if there is any lump on the back. So these children are prone to have recurrent UTI, and you can find actually the cause of UTI, because at the end of scenario there would be definitely some hidden cause that examiner would expect you to find out that what is the reason for this UTI. And you can ask what investigations has been done so far, especially focus on urine culture. You can ask when was done, it was done, where it was done, and what were you told about this. So you have to actually figure out total number of the urine cultures that were done, and where these were done. This would actually give you some clue towards the management strategy, like if there is any previous history of UTIs, and last time there was some bug isolated that was specific to some certain, that was sensitive to some specific antibiotics, you can empirically start those antibiotics next time. And ultrasound, KUB, DEMSA scan, and MCUG scan, you have to ask about these. Ultrasound, you have to ask, was any jelly scan done for the kidneys? And for DEMSA scan, you can ask like, was any dye was given and then X-rays was done, and are for MCUG, you can ask was any soft tube passed from the down area, and then some dye was injected and they did some X-rays. So this is the way to ask about these investigations. You have to ask about these investigation, and possibly in the scenario there would be something already done, or but examiner would actually note down you are taking the history in a systematic manner. And for the treatment, you have to ask about the name of the medication, duration of the treatment given, and number of times the child was treated for UTI, and ask about whether any prophylaxis was started and what antibiotic was started at what dose and what time they are taking for prophylaxis. You can ask about the total admissions done so far, and services the child is linked with. Child may be linked with some nephrologist. So you have to check with the parents, like what services child is linked with, and what is the plan for follow-up, and past medical history, any allergies, any other specific history, any complications, birth, immunization, nutrition, development, family history, social history. These are important. So once the history time is finished, then actually you would have time to describe your findings, and you have to be very focused, tell the positive findings only, and the examiner would expect you to make an impression towards the end of description, whether it was a lower UTI, cystitis, or upper UTI, pyelonephritis, whether it was a typical or atypical UTI, whether it was a recurrent UTI or not, and what is the reason, underlying etiology for this UTI. So lower UTI is cystitis generally, and it is actually only urinary symptoms. Like there would be some increased urgency or frequency. It is called cystitis as well, and there is no involvement of any systemic signs. But if there is involvement of the systemic signs, which can be temperature of 38 or more than 38 degrees centigrade, or flank pain, these suggest upper UTI or pyelonephritis. For the typical UTI is the UTI which generally responds within 48 hours, but the atypical UTI is the one where child presents in acutely unwell condition. It could be septicemia, and the child may have deranged renal function test, or some any atypical bug, any bug else than uh, E. coli would be found out in the urine culture later on, or there are any symptoms suggestive of obstructive uropathy. These all suggest the atypical UTI. And the recurrent UTI, as I have already explained, if there are three or more than three symptoms of of UTI in 1 year, or even two or more than two UTI, and one of those UTI was pyelonephritis, these suggest the recurrent UTI. So investigations actually mainly depend on whether the child is well or unwell. If the child is unwell, in that case, we treat these children as sepsis and pyelonephritis and suspected sepsis. So you have to actually take all the septic workup, including the blood culture, FPC, CRP, UNE gases, and blood culture, urine culture, um, renal function test. So that is the scenario in unwell condition. But in case of well child who is not having any sign symptoms suggestive of pyelonephritis, you will only take the urine for dipstick, and then urine would be sent for microscopy and culture if needed. And for specimen collection, depends on the age of the child, but it is preferred to take the midstream urine, um, and it is sent for culture, and it is actually initially tested for dipstick, and then accordingly it is sent for microscopy and culture. So the preferred specimen is midstream urine, but sometimes the pad sampling need to be done in case the child is very small, but it is not encouraged. Even if the child is less than 3 months or very small child, it is advised actually to give the container to the parents and leave the nappy on. And sometime striking the lateral part of the abdomen stimulates them to pass the pee. It's hard to collect, but it is the reliable one, so always go for midstream urine. So after specimen collection, it is checked for the dipstick, and in dipstick we check it for nitrites and leukocyte estrates. If the sample is positive for the nitrites, and leukocytes both, then in that case you have to send the urine for microscopy and culture and start antibiotics. But if only nitrites are positive and leukocytes are negative, in that case you have to send the sample anyway for microscopy and culture and treat if clinically indicated. And then we will take leukocytes. If there is only leukocyte positive and nitrites are negative, in that case, if clinically indicated, you have to send the sample for microscopy and culture, and then start the antibiotics according to the clinical condition of the child. For the microscopy, in microscopy, we check for white cells. These are the pus cells, and then also bacteria in the microscopy. And we always send the sample according to the clinical situation for culture and sensitivity. Okay. So there are some further investigations according to the NICE guidelines. We have to do sometime ultrasound and MCUG scan and DEMSA scan. So ultrasound, actually, it depends whether you're suspecting a typical UTI, atypical UTI, or recurrent UTI. If the child is having atypical UTI, you have to get an emergent ultrasound. So regardless of the age, if child is having atypical UTI, you have to do an ultrasound at KUB. And if it's a typical UTI, then you have to do the ultrasound only if the child is less than 6 months of age. And in that case, you can get an ultrasound 6 weeks after the infection. But in case of a atypical UTI, emergent ultrasound is needed, and urgent ultrasound is requested while we are treating the child, and try to get it while the child is admitted in the hospital. And in case of recurrent UTI, if the age is less than 6 months, then in that case try to get it early. But if child is having age more than 6 months, in that case you can it's you have to do it after the 6 weeks. So that is about the ultrasound. And for MCUG, if MCUG is actually only indicated if there are any voiding symptoms, or ultrasound has been showing any signs and symptoms suggestive of obstructive uropathy. And if child is less than 6 months of age, it's preferred to do it as well. And if it is a DEMSA scan, and then it depends whether it's a typical UTI or atypical UTI and recurrent UTI. And if child is having child age is actually less than 6 months, and there are atypical or recurrent UTI, you have to get it done. And if age is 6 months to 3 years and child is having atypical or recurrent UTI, you have to get done a DEMSA scan. And if the age is more than 3 year and child is having recurrent UTI, then you have to do the DEMSA scan. So DEMSA scan we generally actually do 4 to 6 months after the UTI. Ultrasound can be done either urgently, and it can be done 6 weeks after the UTI according to the clinical indication. It's preferred to do after 6 weeks just to find out if there is any renal scarring. And MCUG is done after the UTI has been resolved. And in DEMSA scan, it is preferred to do 4 to 6 months after the UTI to find out if there is any renal scarring. Talking about the management, it depends the clinical condition of the child. If you are suspecting the child with pyelonephritis or suspected sepsis, try to manage on the line of the sepsis. All the sepsis 6 protocol, that is take 3 and give 3, you have to complete it. And if the age is actually less than 3 months of age, um, broad spectrum third generation cephalosporins are preferred, and cefotaxium or ceftriaxone we can start with. And if age is more than 3 months, and then you have to actually, according to whether it's pyelonephritis or cystitis. If it's a cystitis and child is clinically well, then oral cephalaxin for 3 days is enough. But if it is a pyelonephritis, then you have to treat with IV augmentin, and you have to complete 7 days. If child is hemodynamically unstable, in that case, gentamicin is started, and later on we can stop it according to the clinical condition. And we always start these empirical antibiotics, and then we chase the urine culture, and then according to the sensitivity we further plan according to the for the duration of the antibiotics and the type of the antibiotics. Prophylaxis is actually indicated when there is recurrent UTI, or the child is having any signs of symptoms of obstructive uropathy until they are surgically corrected, or it's a vesico-ureter reflexes, grade 3 or more than 3, and we have to give the prophylaxis until child is out of nappies. So until the child is incompetent. So sometimes when we have to do the DEMSA scan, or we have to use the MCUG, we prefer to give the prophylaxis until these investigations are done and we rule out any underlying condition. Surgical, if there is need for any surgical correction, like if there is any obstructive uropathy or vesico-ureter reflex, which is of grade more than grade 3 by 6, then according to the advice from the nephrology and urology, we can take decision about the surgical correction. Regarding the follow-up, we generally, it depends on the underlying cause, and if there is any renal scarring, sometimes we have to follow the children in our OPD with annual blood pressure check, and every 3 to 4 yearly we have to check for the renal function test and proteinuria. So regarding the management is always sportive and specific, and sometimes you have to when you these were actually the areas to be covered, but when you actually tell about the management, you have to actually mention like I will provide the sportive treatment and specific treatment, and involve the multidisciplinary team if needed. Like if you think there is need to involve the nephrologist or urologist, you can add their name, and always you have to find out what is the underlying reason. Like in the sportive treatment, again, if child is having constipation, you have to address the constipation. If the fluid intake is inadequate, you have to encourage, give some information leaflet to the parents, and tell them like these are the areas where we can work out. Like you can tell about the lifestyle modifications, take more fluid, more frequent voiding. You can tell them to void after every 4 to 6 hours, regardless whether child needs to void or not. Sometimes they have the retentive behavior and they don't mention to the parents. If there is no obvious cause for the UTI, you can encourage for more frequent voiding. And there is a concept of double voiding. Like when they finish voiding, it's better to tell the parents to ask them to sit down and void one more time for complete emptying of the bladder. So in the examination, they actually really focus on these points. So these lifestyle modifications are very important. If there is constipation, you have to address the constipation. Fluid intake is inadequate, address that. If child is having retentive behavior, try to address that by more frequent voiding and regular voiding. And hygiene of the perineal area is also very important. You have to wipe from front to back. This is especially important for the girls. And then accordingly, there is some pharmacological management and surgical management, and then there is need for the follow-up. So this is about the history station and approach to the UTI. Actually, in the beginning, I forgot to mention about the time. Actually, initially 3 minutes you would be waiting outside, and then you have some enough time to take the history. You would have 12 minutes, and in those 12 minutes, actually, in the last 3 minutes, you would be given the warning like time is going to finish, and after that, your viva would start. So this is how it goes actually. Are there any questions?
Yes, I want to ask, is there examination as well in this history station or just the history taking?
Well, there is no examination. They would actually ask you to take the history and then describe the history, and then the examiner would ask you what are your differential diagnoses, what investigations you want to do, and how you will manage the child. So this is how it goes. Like in the beginning, you will find the scenario, and then you will take your relevant history, and then you will describe your history findings, and then examiner would ask you what are your differentials and most likely diagnosis, and then about the investigations and management and follow-up.
Okay,
Am I
thank you.
clear?
Yes, thank you.
Any more questions? Try to ask maximum questions. This is very important scenario, and it is frequently actually asked in the MRCP-CH examination. So make very clear picture of it in your mind. Any more questions? I think we can finish the session here then. And good luck for your exam. And we will start our next session very soon. And I will meet the students over there and try to make the short notes and focus on the on very pertinent and important points. Don't ask too many questions. Ask very focused question. Tell very focused history, and just save your time. Saving the time, moving to the next points. Try to finish all the points so that you can actually get marks in all the possible domains. These things really help. Thank you very much.